representing 29 organizations across 17 countries with one shared goal, to eliminate cervical cancer. The cohort engaged in over 19 hours of learning from international experts, including 8 experienced faculty members. But before we turn things over to our first presenter, we would like to take a moment to get a quick snapshot of all of our attendees' involvement in HPV vaccination efforts. So, in a moment, my colleague Leah will launch a poll, and we'll give you all a minute or so to respond to that. So hopefully a pop-up box will have appeared in front of you, and I can see people are filling them in. Perfect. Looks like most people have now filled in the poll. So I'm delighted to say that today you will hear sorry, just one second. The poll is keeps on popping up in front of my script here. Today you'll hear brief presentations from 4 members of the Learning Series cohort. And after the presentations, we'll have an opportunity for questions and answers to a panel of all 4 presenters. So please do put your questions for the presenters into the Q&A box when the time comes. Today's session will also be recorded, and we will provide attendees with a PDF of the slides afterwards, so you don't need to take furious notes as they present. So without further delay, I'd like to introduce to you our first speaker. Dr. Annette Nakaganda is the founder and director of the Ananda Center for Cancer Research. She's a clinician and a cancer epidemiologist specialized in cancer control planning and implementation, cancer epidemiology, clinical trials, implementation, science research, implementation science research, public health, health policy, and higher education and pedagogy. So pretty much covers everything, I think. Finally, she is a CCAE series graduate and HPV vaccination champion based in Uganda. Dr. Annette, over to you.
Thank you so much, Alex, for that kind introduction, and greetings to everyone. I'm really honored to present our project for enhancing clinician communication skills to promote HPV vaccination in Uganda. Next slide. Yeah, for those of you who may not know Uganda, Uganda is located in East Africa. As you can see, it's a landlocked country. The population age structure just for that pyramid is relatively young, as shown by the broad base of the pyramid. And as you can see on the pyramid, half of the population is actually under 18 years of age. So it's a very young age structure, and that reflects the economy of the country. And the pyramid is symmetrical, as you can see, which is relatively balanced distribution of males and females across most age groups. And I just put those healthy indicators just to show you that Uganda has a high burden of diseases, including cervical cancer. So next slide, please. So the biggest public health problem now in my area of expertise is that HPV vaccination among girls aged 19 to 14 years in Uganda is below the 90% national and WHO targets, putting many girls at risk of cervical cancer and so many other HPV-related cancers. And although 75% of the population stays in rural areas, coverage is shown HPV vaccination coverage is shown to be higher in urban compared to rural areas. Next slide. So just a little bit of context, Uganda started the pilot of HPV vaccination in 2008 and rolled it out to the whole country as part of the National Expanded Program on Immunization in 2014. So we are more than a decade. And we have introduced a single dose schedule since 2025. And the vaccine is provided free of charge to parents, girls. And it targets 10 years, girls only. And we use static and school-based outreach immunization sessions. There is a catch-up policy at working basis where we can immunize 9 to 14 years age groups. And these immunization schedule is intensified in the months of April and October through the Child Plus program. Next slide. So we tested the hypothesis why clinicians do not recommend 9 to 14-year-old girls to get vaccinated, because we found that is one of the barriers in our setting. And our project wants to help clinicians to recommend HPV vaccination for girls between the ages of 9 to 14 years. So that is our behavior problem that was identified. Next slide. People may wonder how we identified this. We went through quite a rigorous process that involved a rapid assessment of clinicians' perspectives, and we tested so many hypotheses. But the one that stood out that is a major behavior barrier was that clinicians do not know how to communicate and recommend HPV vaccination to parents and adolescent girls, as I will show you the evidence in the coming slides. Next slide. Yeah, so we thought that the best solution to start with now is training the clinicians on communication skills to effectively engage parents and girls on HPV vaccination, and give clinicians short messages to say and initiate HPV vaccination at every consultation visit. Next slide, please. So we worked with key partners, and thanks to this series, because we are supposed to also understand a bit of more context in our own countries to understand the barriers better, we had to contact the Uganda National Expanded Program on Immunization. And throughout these 4 months, they have really formed part of our great partners. We had to do a rapid assessment of the clinicians' perspectives, and we worked with Mukono, which is an urban district, and Chotera, which is a rural district. So currently, this series also helped us form these partners, and they informed so much the design of this project. Next slide. So what we learned mainly throughout this process is that clinicians in Uganda really understand that HPV vaccine is effective, efficient, and safe in preventing cervical cancer. However, many still do not recommend it because of several key behavior barriers. One is the communication challenges. Some clinicians really feel, most of them, they were so unsure about how to discuss HPV vaccination with parents and girls. As one clinician said that, I have not been recommending the vaccine, and there will be need to provide information on how to address sexuality if it is to be recommended. So for her, her worry was like, you can't talk about HPV vaccination without sexuality issues, and she didn't know what to say. Then there was also role perception. Many clinicians viewed HPV vaccine recommendation as outside their clinical duties. As one of them said, HPV vaccination is normally talked about during the health education, and it's not my responsibility during consultations. Of course, there was limited knowledge of the guidelines. Many clinicians did not fully aware of the current national guidelines where the vaccine is provided, for example, and some really still question the efficacy of the single dose schedule. As one of them said, I don't believe the single dose works. They don't work. They have to be 2 doses. Of course, many cited workload and time constraints, heavy patient loads, and limited time to reduce, to recommend reduces the opportunities also to recommend HPV vaccination in our setting. As one said, the lines of patients are long, so we may need maybe reminders if we are to recommend. Next slide. So through this learning series and understanding more of our context, our project we are going to embark on, we even started this month, is to implement this project of training clinicians in effective communication about HPV vaccination. And we are starting with one district for the start. We are currently refining and adapting, and we want to use the existing training materials from preventglobalhpvcancers.org. We are consolidating our collaboration with the Ministry of Health and the first district, and we are seriously advocating for this HPV vaccination communication training to be incorporated into their routines, mainly the CPD requirements and mentorship programs. Of course, we are continuing to seek funding and partnership to scale up this training to other districts, and most importantly, to develop reminders to these clinicians and support wider implementation to the whole nation after one district is done. We thought of how sustainable should we do this. We thought that we could also think about developing and conducting a TOT training so that it is incorporated into the district plans. And that will tell us and will require us to track improvements in this initiative when it comes to clinicians' knowledge about HPV vaccination, their confidence in recommending it, and of course, the overall outcome and impact of the vaccination rates being improved in Uganda. And we shall continue seeking funding, of course, to tackle other behavioral barriers among clinicians, and of course, for the purpose of continuously engaging them in the discussion of cervical cancer prevention. Next. Yeah, that's it. Thank you so much. You can follow us, SCCR, Nanda Center for Cancer Research. You can call us on that phone. You can send us an email. You can visit our website. We're on social media, Twitter, LinkedIn, Instagram, Facebook, and visit our new YouTube channel at Ananda Center for Cancer Research. Thank you so much.
Thank you so much, Dr. Nakaganda, for those really valuable insights from Uganda. It's very much appreciated. And next, we are very fortunate to be able to hear from Professor Amal El-Sisi, who is a professor of pediatrics at Cairo University. She's also a visiting consultant at the Royal Manchester Children's Hospital and has publications in 69 peer-reviewed journals. She's been a Rotarian since 2002 and served as president of the Rotary Club El Tahrir in 2021 and 2022. And she is currently the director of the United to End Cervical Cancer in Egypt project, which runs from 2023 to 2027. It's a great pleasure to hand over to you, Professor.
Thank you very much indeed for this introduction. I'm very happy to be with you today and talking about our experience in United to End Cervical Cancer in Egypt, which is a fairly new program started in 2023. And our topic today is about bridging the gap in doctors' knowledge of HPV screening and vaccination. Next, please. So the public health problem that we have in Egypt is low uptake of HPV vaccination and cervical cancer screening. Actually, the cervical cancer screening in Egypt is recorded to be less than 5% of women, and the vaccination is not supported by the national immunization program. So it explains why the uptake is low. However, we're going to address also the knowledge gap in doctors, which is a behavior problems. Even the national immunization program in Egypt does not support all the vaccination schedule. For example, the pneumonia vaccine, the rotavirus vaccine are not also supported by the national program. There are other vaccines that are not supported. However, doctors do recommend them for their patients, but they do not recommend consistently the HPV vaccination to parents of girls aged 9 to 15. Doctors need to actively initiate vaccine discussions and recommend vaccination as a routine preventive service. It is their duty, regardless of the government providing the vaccine or not. It is the doctor's duty to explain to the parents the importance of this vaccine and other vaccines that are not on the immunization program. Next. The barriers are they do not recommend the HPV vaccine to parents of these girls when they consult them for the HPV vaccination. What is in the way of doctors to recommend HPV vaccination? It is the lack of training on HPV and cervical cancer, the limited awareness and knowledge of HPV prevalence, the misperception that HPV is not a major public health issue, that they do not need to recommend it, and it is not their duty among their busy schedule. And because this vaccine is particularly given to adolescent girls and boys in some countries, of course, they usually recommend the vaccines in early infancy as pediatricians. Next. Now we identified this problem through in our program through a doctor survey, which covered 508 respondents. It was a Google form survey done by WhatsApp messages, and it included different doctors with different experiences, ranging from less than 5 years to more than 10 years, equally distributed in 3 groups, more or less. Mostly were pediatricians. However, there were also other specialties like gynecologists, clinical pathology, and oncology. The practice type, as it is practiced in Egypt, there is 50% private practice and 47% academic, and also hospital practice, which can be private or academic. The key knowledge gaps, 54% were not aware of the latest HPV guidelines. They are unaware of the latest vaccination guidelines. 33% did not consider it a public health problem. Were unsure, and 43% did not know about cervical cancer prevalence or the relation between HPV and cervical cancer, and 58% did not know how frequent the HPV screening should be done. Next. So what are the solutions we are suggesting? We are addressing the gap in knowledge among doctors. We are planning to conduct HPV awareness workshops for doctors, train doctors on addressing parental concerns, provide evidence-based fact sheets, engage also a very important part in Egypt, in the public, the social leaders, to influence the mothers in the communities, because they are very influential in our community. Next. The lessons learned, that doctors' HPV knowledge is extremely low. HPV vaccination is not prioritized. Doctors do not view vaccine recommendation as their duty among their very busy schedule. The peer influence affects the physician behavior. Some doctors, although they know the importance of HPV, there's a behavior problem. They still don't recommend it. HPV vaccination age is at adolescence, not coinciding with other routine vaccination, which mainly happens in infancy. Next. So our next steps will be to offer workshops and awareness training for medical staff, mainly doctors, on HPV-related health services, screening, vaccination, and referrals for cervical cancer treatment. Train doctors on frequently asked questions from parents, because it's a sensitive issue in our conservative society. Provide doctors with briefs and facts about HPV and cervical cancer prevalence in Egypt. Our preliminary results showed that the carrier rate in our community is actually 10%, which is much higher than was thought in the past. And also involve the social leaders by training to influence the mothers, because they live in the same communities as the mothers, and they are trusted in the community to seek the HPV vaccination for their girls, even if it is not provided yet by the government, until it is provided by the government. Next. So we have a lot of key partners in our program. We have the Rotary clubs in Egypt, which are around 135 clubs. We have the youth in the Rotary Act members. We have the scientific societies, the Ministry of Health, the presidential initiative, which has started already the screening for HPV, but not yet the vaccination. We have started some pilot vaccination in schools with the cooperation of the Ministry of Education, and also started in the youth and sports centers. We engaged the WHO Egypt office, the scientific professors of gynecology in the universities, mainly Cairo universities, the National Council for Women, the National Council for Motherhood and Childhood. Next. And a lot of NGOs who can gather the women from these areas, and because they are trusted NGOs in the neighborhood, so that we can spread the awareness, because it is not only that the vaccine is not available. In some countries the vaccine is available for free, but yet the awareness among the public is not good enough to take the vaccine. Next. So you can learn more about our program from our website, Facebook, Instagram, LinkedIn, and our program goals and beneficiaries over 4 years is to reach awareness 4 million at least, screening 15,000 women, and vaccination of 32,000 girls. And of course, for the first time in Egypt, we will have structured data collection and analysis to understand more about the problem and how to address it, and to influence the government to implement the WHO guidelines 90/70/90 before 2030. Thank you.
Thank you so much, Professor. It's great to hear about such an important and ambitious program, and interesting to hear some of the similarities and the challenges with Uganda as well. We now move from Egypt to Malawi, and it's my pleasure to introduce Mr. Hope Banda. And Mr. Banda is a health professional with training as a clinical technician and a medical technologist. He currently serves as a project officer and a cervical cancer focal person at the Coalition of Women Living with HIV and AIDS, where he supports the implementation of cervical cancer advocacy, prevention, screening, and treatment initiatives. Hope, over to you.
Thank you, Alexander, for the wonderful opportunity. I'm going to take you through a case study of which I wanted to enhance cervical cancer prevention by introducing HPV vaccine into routine health passport book for girls. So our public health concern, cervical cancer remains one of the leading cause of death among cancer-related death among women in Malawi. So we feel like HPV vaccine uptake among adolescent girls is low due to myths and misinformation and limited awareness among parents and guardians regarding the HPV vaccine. Next step, please. So our behavior problem was parents and guardians do not take their daughters for HPV vaccine, or they do not recommend the vaccine despite its proven safety and effectiveness. So parents need to take their daughters for HPV vaccine so that we should reduce this burden of cervical cancer. Next page, please. So barriers, and here we usually have misinformation and also myths about HPV vaccine, and also vaccine hesitance among parents and guardians is also another thing. Limited awareness of benefits and safety of the vaccine is also another challenge. HPV vaccine is not included into the health passport book here in our country, of which we noted that a parent or guardian will make sure that he or she take her daughter for vaccine, all the vaccines that are in the health passport book. So the HPV vaccine is not in the health passport book. That's why it's having some challenges to to be recommended. Another thing is funds and constraints. Funds constraints that lowers awareness and engagement. With the current fund freeze, there's no money for awareness. Other organizations which were doing awareness campaigns, they have ceased, so they are still low awareness and engagement of activities regarding HPV vaccine due to these funding constraints. Next page, please. So solution to the problem, as Cora will conduct community dialogues, awareness campaign, social school-based sensitizations, and also we can also host radio and TV programs to feature experts to debunk the myths which are circulating around. Advocate for integration of HPV vaccine into health passport book for girls, which is our main focus, so that if it's documented in the health passport book, parents will usually take their daughters for HPV vaccine. And also engage community leaders, faith group, and also traditional authorities to build trust, since people in the community will trust their leaders and also their faith leaders. Next step, please. So with this activity, we thought of partnering with the Ministry of Health, district health officer, district health office, district executive committee, community leaders and traditional authorities, faith group, radio stations and TV, and also a network of CORA members, of which CORA right now has registered over 73,000 women who are living with HIV are being registered under our organization CORA. So we wanted to take opportunity to use them so that they should spread the news to debunk the myths that are within the people in the community. Next step, please. So lessons learned. Many parents lack accurate information about HPV vaccine. Rarely, they rely on community leaders for guidance. Myths and misinformation significantly influence parental decisions. So, because a mother has heard something about some vaccines, she also include it to the when maybe someone is telling her daughter to get the HPV vaccine. So that's it. And the absence of HPV vaccine into the health passport book, doubts and role prioritization among parents. As we say, we want to integrate it into health passport book so that we should lower the doubts, and it should be prioritized by parents so that they know that I have a child at a certain point, at 9 years to 14 years, she has to receive the HPV vaccine. And also we wanted to use the multi-channel messaging to give out messages to people through their phones or social media and radios and TV, so that if they can see the messages now and then, they can recommend the vaccine when their daughter is due for the vaccine. Next slide, please. So the final step is finalize and submit advocacy for updating the health passport book to include the HPV vaccine, seek funding to scale up the community awareness to more districts, and strengthen partnership with the Ministry of Health for sustainable HPV vaccine messaging, expand digital messaging strategies to reach more partners, especially in rural areas through radios and community engagements. Next. So you can find us through these websites. We are on Facebook, LinkedIn, and also Instagram. So thank you for the wonderful time.
Thank you very much, Hope. It's great to hear of the wonderful work being done by Cowler. Really, really important. Uh, we now jump continents from Malawi to Pakistan, and we will hear from Mr. Kamran Khan. And Mr. Khan is a public health professional with over 10 years of experience in immunization, social and behavior change communication, MNCH, family planning, and health system strengthening. Led and supported by USAID, BMFG, and UNICEF funding, and closely working with government, UN agencies, and civil societies. Mr. Cameron works with Jipaigo in Pakistan. I'll hand over to you. Mr. Khan, are you there? There we are. Perfect.
Hi, good evening.
Good evening.
Thank you for the opportunity. My name is Kamran Khan, working with Chipaigo in Pakistan as a social and behavior change manager. I am thankful to the CCA, American Cancer Society, UK Research Society, for giving me the opportunity. My study which I am going to present is bridging the knowledge gap in engaging and empowering caregiver on cervical cancer and HPV vaccination in Khyber Pakhtunkhwa,
Amran,
Pakistan.
I'm sorry to interrupt. Your slides are not showing in full screen. Can you put on the slideshow?
Okay.
Thank you.
Yes. No, it's visible.
Yes, this is perfect. Thank you.
Thank you. So the public health problem in Pakistan, where I am working in the province Khyber Pakhtunkhwa. We have conducted a knowledge attitude behavior study with the support of JPIGO in collaboration with government health department. So as per the finding of the research study, there was low awareness and lack of foundation knowledge of cervical cancer and HPV vaccine among parents, and only around 3% of the parent were know about the HPV and its prevention. So, at journal there is low awareness about HPV and its vaccination and cervical cancer. So the behavior problem is low acceptance and parent refusal to the HPV vaccination. Pakistan has decided to introduce HPV vaccine in phase wise. So the first phase was in 2025 and targeted two province, and in next phase where I am working is the province Khyber Pakhtunkhwa. So in first phase we have a lot of parental refusal, low acceptance in community. The barriers which were reported or which found mainly were the myths and misconception about HPV vaccine. People or parents were saying that why you are only vaccinating female. At the same time, there were low perceived need for HPV vaccination, anti-HPV vaccination propaganda on social media. Some of the parents were have a fear of side effect or infertility or hormonal imbalance. These were like the main barrier around the HPV vaccination in the mind of caregivers. So the strategy which we are trying to implement, or the solution, is to develop SBCC strategy, engage parent with clear trusted information through ACSM and community awareness activities. use of IC material with government endorsement to build trust, and counter the negative propaganda, promote positive messages from the trust from the voices like Pakistan Pediatric Association or Gynecology Society, influencers, policymaker, religious leader. So these strategies will help us to remove the misinformation, increase confidence, and encouraging parent of the adolescent girls who we are targeting in next phase. The key partner is the government health department, specifically the expanded program on immunization. We have partner like UNICEF, WHO, Gate Foundation, Gavis, and CSOs. Similarly, for building trusting and more engagement of the other stakeholder, we are trying to engage the medical association, community, and religious leaders. So key lesson learned is that there is a lack of awareness about HPV vaccination, and people believe the HPV vaccine is not necessary or unsafe. It causes early puberties. Like some of the parents or some of the caregiver influenced by the family member or from their community or friends. At the same time, we have noticed that parent call this disease like a Western disease, and we have a very low prevalence of this disease in our country. So that's why our people consider it like a sexual transmitted disease, more like a Western disease. At the same time, parent like Pakistan is a low middle income countries, so there are many other challenges, and parent always ask for other basic need or for other resources. The next step for phase two, we will try to extend our SBCC activities at national and provincial level. We will try to use clear and concise IC material to counter the misconception which we have specifically in the first phase of the campaign. We were during the first phase of the campaign, we were continuously recording or keeping the record of the social media trends, that what are the main reason like people are refusing. So in next phase we will also use extensive use of all social media platform. Unfortunately, the first phase was badly affected by the TikTok, and unfortunately, we missed TikTok in our campaign strategy. We use mainly Facebook, WhatsApp like platforms. SBCC and ACSM activities, community mobilization, health help, environment, healthcare practitioner, medical association, engaging key religious and political leaders, and most importantly, this time we will also engage the parliamentarian, mainly the female parliamentarians. So you can learn more about the JPIGO through our LinkedIn page. Thank you very much.
Thank you so much, Mr. Khan, and thank you to all four of our speakers. And those been four really informative and enlightening presentations. We now are grateful that our speakers have agreed to stay on to take questions. So please do put your questions into the Q&A box. And I will start, I think, feeding in some of the questions that we've received. And I'll start with a question for Dr. Annette. A question has come in about whether you experienced any difficulties or pushback from the immunization program and colleagues working in immunization when you began working with them. What was that relationship like?
Yeah, actually, surprisingly, they are very warm. They were very welcoming. Dr. Immaculate Impaire and her personal assistant Brenda were very welcoming. We even requested for Zoom meeting. They accepted and did a Zoom meeting because we had initially responded to the Cancer Research UK grant about the same. So when we contacted them, they gave us all the information. They even reviewed the grant and told us where the most challenges were for them and where we can help. Yeah, although one of them, we are not addressing them with this current problem. For them, they thought the messages to the parents were biggest problem, but as well as doctors' recommendations. So they are very hopeful and they are very excited that finally we are starting to support them. They didn't have any civil society organization supporting their work when it comes to HPV vaccination.
Thanks. That's really good to hear, and hopefully something that can give others confidence in approaching the immunisation community in their contexts. Professor El-Sisi, if I could come to you next, and we've had a question about the doctors' survey. You obviously had a really good number of responses, and the question is around how did you sample participants for the survey, and what were the challenges that you experienced, if any, around the survey itself?
Right. The sample was random, so it targeted mainly doctors in specialities relevant to HPV, which are pediatricians, gynecologists, also clinical pathologists who do the test, HPV screening test, oncologists, and they were sent through the syndicate. So they were anonymous. We did not know the responder's name or anything. We could not come back to them for any other questions. But the challenge was the poor response, which is expected in such surveys among doctors. Doctors in Egypt, I think, like any doctors worldwide, work very long hours, overworked, underpaid. And to answer a survey, to get 500 responders, we targeted much more. We engaged the young doctors in their training years, the house officer year, to help with pushing for answers and following with the Google forms through WhatsApp. WhatsApp is a very common communication in Egypt among everybody. Actually, is using WhatsApp nowadays, and actually, it's also a good way to message to target the doctors and give them repeated messages, which we also thinking about besides the social media and the usual training and so on.
Fantastic. Thank you very
And we use Google Forms, the simple,
Right.
just very simple Google Forms, and the Google Forms can do the analysis for you at the end, very simple percentages
Great.
and so on. Yeah.
Thanks. Really useful practical advice there around some of the tools as well. Hope, if I come to you next, we have a question about Malawi. And you mentioned that one of your next steps is advocacy for the integration of HPV vaccination into the health passport books. And the question is, what kind of activities are you planning around that, and what might this advocacy look like in your context? I think quite a few people face those kind of structural barriers. Is that how HPV vaccinations are included in national frameworks? So be really useful to hear your reflections on Malawi.
All right. Thank you, Alexander, for the nice question. We are having two approaches. The first one is to involve the Ministry of Health about the introduction of the HPV vaccine into the health passport book, and see their view on it. If they accept or usually go for demand creation in the meet people, to tell them that we are introducing this vaccine into the passport book. How are you viewing it? Are you going to be able to recommend the vaccine just because it's in the health passport book? Now, are you going to believe that it's a good vaccine because it's in the health passport book? So after that, we'll see the response in the form of, like, we're creating demand. After, when the demand is created, that's when we'll write a policy brief to the Ministry of Health, that I think this now is a priority because people, they are going to buy it, they are going to accept it. So that's how we plan to do it. Sure. The activity are going to rotate around that one, so that it should be from the people, not from us, because we can be with the Ministry of Health, include it. People are not aware in the community, and people, they'll just be saying, "What's that?" We don't know it. We know we were giving maybe 12 vaccines. What's this one? The 13th vaccine. So that's the approach we used. Thank you.
Thanks. Yeah, again, really important to hear that, or to emphasize the importance of that community voice in bringing about change. Mr. Khan, a question for you in Pakistan. What has been successful in addressing the notion that HPV and cervical cancer is not a concern in Pakistan? And following on from that, when you had the challenge with TikTok, how did you pivot your work? How did you adapt to that challenge? Mr. Khan, are you still with us? I think perhaps some connection issues there. No problem at all. Well, so I've perhaps got two more general questions. So all of our panelists have mentioned, I think, the importance of partnerships in their work, and I wondered, it's open to all panelists, if you had any reflections on the importance of partnership in the success of your work, and any lessons that you've taken from that. Any one of our panelists like to jump in there?
Can I answer that?
Yes. Yeah.
Yeah. Partnership is very important. It's actually pivotal in success of a program like a new program, especially in our country. It's a very fairly new program. HPV vaccination, HPV awareness. You have to get everybody on board. You have to get, of course, the government, because you want to persuade the government to put it in the national immunization program. All the NGOs, because they can reach the community easier. The medical staff, of course, the private sector, the universities, the scientific committees, to make the evidence very clear about the safety and about the long history now of and the follow-up 20 years of the vaccination. You have to have the data analysis to prove that this disease is carrier rate is higher than we thought it is in Egypt, because the objection in the past was that we don't have cervical cancer. It's a rare disease. It's actually underreported, and there are no data available to support whether it is there or not. But with our program now screening over 10,000 almost 10,000 women, we have a carrier rate of 9.6%, which is high, which is not different than the Western country, and not relate the HPV disease to sexually transmitted disease, because it's a taboo area, but just we want to prevent cancer, and we want to save the women and the girls from a fatal disease. So everybody should speak the same language. We should meet together and we should work together, and there has to be partnership, of course.
Yeah,
Thank you.
maybe to add on for me, of course, one of the reasons I had to partner with those partners was strategic to make sure that the final outcome of the effort is achieved. For example, I had to partner with the UNEP, the expanded immunization program, one, to understand the context also myself further, but two, to make sure that the vaccines is there, because even if I train the clinicians and they recommend and the supply, the vaccine is maybe there is stock out and everything, it will not finally achieve the outcome. So that's why we have to involve them from the word go. I involved the district health officer because as I was doing the risk assessment for my project, if the clinicians don't turn up for the training, then the project would not achieve the outcomes. So I want to use them to help invite the clinicians to the training and also be there to give sort of political voice and perspective of how important HPV vaccination is to their staff. So it's all about achieving what we have to do, because we are not doing it all ourselves, and it is through the interlinkages of different parts of the stakeholders.
Thank you so much for those reflections. Cameron, if you're back online and with us, we did have a question for you, which was around the approach to addressing the notion that HPV and cervical cancer is not a concern in Pakistan, and with regards to the challenges you had with TikTok, how you responded to that challenge. Are you there, Cameron? Perhaps not. I think connection's probably coming and going a little bit. In
Hi,
which case, oh, you're there.
hi.
Wonderful.
Yes. So, like, can you please repeat? Sorry, in our area there is some network issue.
Yes, of course. So the question was around how you addressed the idea that cervical cancer is not a concern in Pakistan, and then particularly the challenge. How did you deal with the challenge that you had with TikTok, and how did you adapt your work?
Uh, yes, like unfortunately, we have cervical cancer, but we have no record of the cervical cancer. Like there is no cancer registry, no screening program. So that's why the cervical cancer number is very low. But like the oncologist or the high level gynecologists consider that it's just like a tip of the iceberg. Like we do not have so established screening system. That's why we are missing thousands of cases. So like as per basic data, we have around 5,000 cases per year. That's why people consider it like not a huge burden of this cervical cancer. One thing. At the same time, we have some other major issues that which people continuously facing. So that's why people are more thinking about the issue which they are actually facing. That's why they are less toward the cervical cancer or HPV vaccination. The second question, like in first phase, there were many videos on TikTok, and unfortunately, in those days, like it was so trending that some of like the social media peoples were trying to increase their views or their channel views, and they were propagating such news on the media about the HPV vaccination. Not it's like never true, but to increase their own channels. So for that, we have started a risk communication and social media engagement more, expanded it extensively, started it, and the health minister we have the federal health minister, and on second day of the campaign he come forward and he vaccinated her daughter in front of the media for HPV vaccination, though his age was above the target age, but for the community trust he vaccinated her daughter in front of media. And some, like most other policymaker, did the same thing, and they share positive messages on social media. So, as the campaign concluded, so we have covered around 72 or 73% of the target. Thank you.
Thank you so much. Um, I think perhaps I'll move to a a final question that goes to each of our panelists. Um, if you had one piece of advice that you could give to colleagues here from another civil society organization if they're just getting started in the HPV vaccination space or are looking to increase their activity, what would that be? Or it could be something that you learned during the learning series that you think would be helpful to others. And perhaps I'll put that question in the order of our presentation. So, Dr. Nakakanda first, please, and then Professor El-Sisi.
Yeah, what I could tell our civil society organizations, especially in low middle income countries, when it comes to cervical cancer prevention, is that what we can actually do now is to prevent the occurrence of cancers because it is almost impossible or it is too hard to really manage them. And that's why we should put a lot of effort in HPV vaccination. Two, we should move beyond what I learned from the series, beyond the knowledge, and tackle the behavior aspects of doing things. People may know that HPV vaccine prevents cancer, but we need to address the behavioral barriers. And it takes a lot of effort and learning. I didn't know this, although I was a clinician before this series, and I learned a lot. I'm a cancer specialist for the last 20 years in it, but I learned a lot. So that's what I can say, that continuous learning process and addressing the behaviors towards cancer control is very, very important. Thank you.
Fantastic. Thank you. Professor El-Sisi.
Yes, my advice or my learning would be the persistence. It's never one awareness session or one message. It doesn't work. You have to do it again, again, again to get the message through. We have in Egypt maybe a different situation than the rest of the countries, that we don't have this vaccine for free. So it needs more effort to persuade the people and go buy it or let their insurance companies buy it for them. So it needs them to be convinced that they will protect the girls from cancer when they buy this vaccine, and it has to be a persistent message. The other thing that we learned in our program so far is the doctors. The doctors are the main players. The family doctors, the general doctors, the pediatricians are main players in convincing the public and the patients. And the way the doctors pass the message is very important. The doctors have to be very assertive. They don't leave the decision to the parents. It is not really a choice. It is a must. They have to give the parents this assertive message of the necessity of the HPV. And I think we need to train the doctors more so that we get the public to demand the vaccine and then persuade the government to put it in the national program. Thank you.
Thank you. That's a really lovely, clear message as well. Hope, do you have any reflections on this question? What one piece of advice would you give?
All right, my piece of advice is to the CSOs. They have to know that knowledge is a precursor for behavior change. So for cervical cancer, there is need of more awareness to give out knowledge so that people should undergoing the screening activities. So we should not undermine cervical cancer. It's one of the leading cause of death, despite the other diseases. It's also causing a lot of death to women. So we need to put in effort. We can see our whole goal of 90, 70, 90, of which if you look at HIV, it was 90, 90, 90, and other countries has reached 95, 95, 95. They are doing well. So ours is still raw, being at 90, 70, 90. We can do better and proceed to 95, 95, 95, or also reach to 99, 99, 99. So we really have to put in effort in terms of awareness and also push the government to at least have HPV vaccine in stock, because that's the main key for the future generation not to have cervical cancer burden. Thank you.
Fantastic. Another really positive message there that we can reach those targets. And finally, Cameron, any reflections from you on lessons that you would share? One piece of advice.
Thank you. So, like the key learning which I have learned is that for HPV vaccine, we must more talk about the cervical cancer. Like we should framing our HPV vaccination key messaging as the most preventive source of cervical cancer prevention. At the same time, we should like increase our community engagement and engagement mainly the trusted voice. Like sometime in our community, in every community there are people who are more trusted. So engagement of trusted people like the gynecologists, the oncologists, the healthcare providers, family physician who should talk about the cervical cancer and with the same time on HPV vaccination. So these are like my two main key learning or suggestion. Thank you.
Fantastic. Well, thank you. And thank you to all our speakers for so generously giving of your time and your knowledge and your insights. I think it's been fantastic. And I hope everybody's taken something valuable away from this session. But to make sure we keep on making these webinars as good as possible, be really grateful if you could take just a few seconds to share your feedback on today's session. We'll launch a poll in just 1 second. And we'd really appreciate it if you can fill that in. And we also very much hope that you'll be able to join us for our next 2 sessions, which will take place next week, so January the 28th, and then the week after on February the 4th, where you'll hear from some other members of our cohort. But again, thank you so much. I see Nina's put the registration link for those next 2 sessions in the chat, and we'd be really grateful if you take just a minute to give us your feedback via the poll. But thanks again to all our speakers and to everybody for attending today. Thank you so much.